Welcome back to Against the Grain. My name is Dr. Samir Kakodkar. I'm a gastroenterologist and specialist in ulcerative colitis and Crohn's disease. Today, we are going to talk about worm therapy for inflammatory bowel disease. The oldest known human mummy was found in 1991, frozen in ice near the border of Austria and Italy. They named him Otzi, and scientists figured out that he lived around 3,300 BC. They studied the intestinal contents and found that he did have whipworm infection. A lot of people had worms in the ancient world, but hardly anyone in the Western world has them anymore due to better hygiene. We also see more diseases of immune dysregulation in the Western world as well. Are these observations related? Today we speak to Garin Aglietti, an expert in helminthic therapy for autoimmune disease. As a disclaimer, as always, this is a frank conversation about his experience in this field, and this is by no means an endorsement of this treatment for inflammatory bowel disease. Any treatment you decide to go forward with should be discussed with your gastroenterologist. Garin, thanks for coming on the podcast. So I just wanted to start off by asking, can you tell us about your background and why you got into giving people worms for autoimmune disease?
Yeah, it's quite the journey. And I had grown up in a family, my parents were medical practitioners, and so I always wanted to be a healer in some capacity, and started medical school, but I was not a great fit for medical school. And between first and second year, I took a clinical preceptorship and was put on a drug study for non-ulcerative dyspepsia. And unfortunately, that drug we were looking at turned out to be not very safe. And even though we got human subjects approval, we decided not to pursue that experiment. And I wound up leaving because that's actually a pretty ugly situation to find yourself in as a second-year medical student, having human subjects approval and being pretty convinced that you have a dangerous drug on the market. So I left, and I continued to research non-ulcerative dyspepsia because that was just fascinating to me, right? There's a condition that describes a stomach problem without any visible ulceration, but nobody really had any idea what was causing that. So after years of study, chasing that thing around, I got the idea that maybe it wasn't something new in our environment, a new disease, but maybe something old, something that we had taken out that was revealing the solution to a problem that now, in the absence of that problem, was creating new problems. So if you start looking at the gastrointestinal tract as an ecosystem, and you start looking at the things that were taken out, you come to the bacteria, and then the worms, or the large multicellular creatures. And if you think of the gastrointestinal ecosystem, you have these trophic levels, right? You have the gastrointestinal epithelium, you have the mucus layer, and then you have, what lives in and on top of that mucus layer. And, you start going back through the epidemiology, and you start thinking about analogous systems like soil, and you start to realize that ecosystems are all interconnected. And when you take stuff out, you become responsible for the function of that organism in the ecosystem. And you can do that to a certain extent with chemicals, but they're poor proxies in that they will solve some problems, but the nuances in ecosystems makes it very hard for any single cocktail or a cocktail of chemicals to recreate what something does. The analogy I use is, if you kill all the hummingbirds in a mountain meadow, you become responsible for the function of hummingbirds in that meadow. And you can do that up to a point, but there's usually consequences to going down that route. And eventually you get yourself to a place where if you strip enough life out of any ecosystem, it becomes so fragile and self-limiting that it collapses. So that was the idea, that maybe instead of using chemicals, pharmaceuticals, that we could start rebiosing the gastrointestinal tract. And this was an idea that was starting to become fertile about 15 years ago when I was thinking about it. Well, I wasn't the only one. There's a number of researchers. And, fast forward 15 years and you see the explosion of growth in the fecal microbial transplants, and following sort of quickly behind is the idea that the large multicellular creatures are a part of that ecosystem also. So it's not just the bacterial lawn, but it's also the amoebas, the worms, funguses, all that good stuff.
It's interesting you mentioned functional dyspepsia, and since you were in medical school, we still don't know what causes that condition, and I have not heard many people talking about microbiome or the gut ecology in relation to why that condition happens. And just for people who are listening who don't know what that is, that's generally any kind of discomfort, pain, discomfort. Sometimes it can include heartburn or just feeling like full or bloated after eating, and usually that discomfort centers in like the upper abdominal area. And you do an endoscopy and there's no ulcers and there's no like H. pylori, a bacteria that can sometimes be responsible, and then they call that functional dyspepsia. So still to this day we tend to use like antacid medications or even like tricyclic antidepressant medications because we think it's more of like a gut sensitivity thing, like it's a hypersensitive stomach, like it doesn't relax properly, something like that. But really we still don't know what truly is the cause of that.
Right. The here be dragons part of the map. The area I'm getting very interested in is it seems that in a lot of the mammalian immune systems and the neuroendocrine systems, there is this interface between the bacteria that lives in the colon and specialized immune cells that make precursors to our neurotransmitters. And so the deficiency of those endospores can create this functional deficiency of these neurotransmitters. And it can be up to a third to half of the body's pool of things like dopamine, serotonin. And serotonin in particular has a really important role in gastrointestinal motility. Mm-hmm. And so if you have 2/3 of your body's pool of this very important substance, you could see how you could start to have these problems. And you mentioned the tricyclic antidepressants, which work have a functional mechanism through serotonin receptors. That is the drug that we were studying way back in the ancient days was a serotonin agonist. It binds to serotonin receptors.
Okay.
And so again, it's this idea that you can strip enough life out of an ecosystem to break it. And, then you have different routes for how you're going to fix that break. You can put serotonin or drugs that enhance serotonin receptor activity, or maybe if you can do it safely, you start to put the life back in, maybe not the stuff that was causing problems, but the collateral damage of that extinction event or those extinction events. Mm-hmm. This all goes back to ecology, right? How do you manage an ecosystem? You got to be real careful going into an ecosystem and saying this is good and this is bad, right? It's all shades of gray, and it's better to steer an ecosystem where you want it to go than to try to tell it what to do. That command and control model it doesn't seem to work very well in these large self-organizing systems.
So how did you go from this idea of targeting the ecosystem and getting to using worms and starting the company that you run now?
Well, I was sick myself, right? I was born in 1971, and that was a time where very few mothers breastfed. Right? It's very uncommon for mothers to breastfeed for any significant amount of time in America. It was believed that the formulas were a better, more scientific product. And so I, like many children of that generation, developed terrible allergies. And those allergies created infections in my sinuses that necessitated multiple courses of antibiotics. And, that's all my first memories were of allergy attacks and infections. And, there's just really nothing really good you can do for it, right? With Kenalog shots for a while, Benadryl and antihistamines, but they're all poorly control the allergy reactions. And then in the 20s, I started to develop psoriasis, and that's the one that really scared me because that felt like it was killing me. So I had the raw materials to do a pretty interesting experiment. Even though it was just an N of 1, I became convinced that maybe if I put some life back in my gastrointestinal tract, I would be able to solve some of my allergy problems. And it made sense, right? Because that arm of the immune system that causes allergies is responsible for attacking large extracellular invaders. So it was really a rather simple idea that if I gave my immune systems its evolutionary target, that maybe it would give me some relief from some of this inappropriate signal detection I was getting from the immune system. And I went to Africa in 2005 and collected some beef tapeworms and ingested them and had a really nice response to that. And that was kind of the beginning of all of this, because once I realized that there was another path to dealing with these chronic conditions, I realized that there's not a whole lot of people that are going to have the skill set or the resources to go to Africa and collect beef tapeworms, right? So then the idea was that maybe we could set something up clinically so that people who are really sick could have access to this experimental therapy.
And how did you specifically go about getting those worms? Because obviously it's very difficult to find access to parasites and worms in Western countries. So what did you specifically do to inoculate yourself?
Right. So in the state I grew up in Nevada, beef tapeworm is considered a public health nuisance, right? Not even really a disease-causing agent. So it seemed rather safe. And it's a large worm, right? So you collect it out of a cow, and it is so large you don't need microscopes or anything like that. But as you mentioned, the problem is you have to go where the life cycle of this organism is still intact, and there's not too many places where people are keeping livestock in close proximity to their houses and then guarding them at night against the land predators, right? And so that is there was only a couple places on the planet I could go to find them, and the eastern Horn of Africa is where I went, right? Because you still have traditional grazers who are building temporary boma fences, keeping the cattle inside the boma fences to protect them from the leopards and the lions. And when they're guarding them at night, they're going to the bathroom inside of the boma fences, and the cattle are grazing in there, and they are picking up the beef tapeworm ova, and they're the intermediate host in that life cycle. And then when the cattle then sell their cows or kill them and butcher them, and then the cysts are in the meat, eat the meat, right? So in this part of Africa, they had recognized that this parasite was in the meat, and the government had set up programs at the slaughterhouses where public health officers would come and inspect the carcasses at slaughter. You'd make 3 cuts in the triceps, and based on the number of cysts that are visible, the carcass can be sold or it has to be condemned. So I could just buy those condemned carcasses because they weren't going to be used anyhow. They're either going to be burned or they're going to be buried. And they were filled with cysts, right? So you collect those, and then you activate a couple of them to make sure you've got some live ones. We sacrificed a pig, cut its gallbladder out, and collected the bile, and then used the bile to activate the cysts to make sure they were alive. And then from that batch, I ingested 2, and then you wait and see what happens. It's not typical to get any definitive evidence of a beef tapeworm infection until you start to shed the proglottids. And anybody who's had a pet, like a cat or a dog, and he's found those little rice-like pieces that are motile, that's the same thing. You're just waiting until these proglottids migrate out of your gastrointestinal tract. And that took 107 days. But in that 107 days, I had a remarkable transformation in my reaction to pollens, and I had some airway reactivity issues that were exacerbated by cold, and it was just a dramatic change. Now, when I got to day 107, I didn't like the proglottids migrating out of the gastrointestinal tract. That was unpleasant psychologically, and so I killed the worm, and then revisited my initial research on what worm might be better to try to coexist with. And I had eliminated hookworm because it has this transpulmonary cardiac migration that scared me. Mm-hmm. But now, with the results of my beef tapeworm experiment, the risk to reward had shifted for me. And I started looking closer at that issue and became convinced that it really wasn't that big of an issue, right? That the billions of people on the planet have gone through that transpulmonary migration. And unless you have a very, very rare cardiac defect, there's probably not much danger in having some worm larvae pass through the chambers of your heart, one heart in particular.
So you mentioned hookworm, and that I'm assuming is one of the major treatments that you are offering people. But just to go into a little bit more detail about how the inoculation happens and what actually happens to someone when this treatment is administered, like how do the worms travel through the body and end up in the GI tract where they have their effect?
Right. Okay. So there's some species-specific behavior in hookworms, and I only work with one, Nicator americanus. And so I'll describe, what Nicator does. There's some variation in other species of human hookworms, but Nicator in particular, you place it on the skin, travels through the skin, and it finds a blood vessel or lymphatic vessel, and then gets into the cardiovascular system, where it rides up to the base of the lungs, between the pulmonary capillary bed, where they're too large to pass through. And they go through a molt there, and then they migrate up through into the lungs. And the ciliary escalator, the way we clean our lungs, brings them up to the back of the throat, and then you swallow them down when they're there, and they go into the gastrointestinal tract. So it's got this long, tortuous journey from skin to where it's going to be residing. And that takes somewhere between 3 to 8 days, depending on the individual. And then it hides, goes through its final molt, and takes its first blood meal about day 19 post-inoculation, or when you get exposed to them on your skin. And then they'll start to communicate with one another and have sex with each other, in that they don't expand the population, but they do start secreting ova, which then need to pass out of the body and go through a soil phase. So it's not that the population gets bigger when they're in there, but the immune system is seeing a lot more worm protein now, because you've got ova tumbling the entire length of the gastrointestinal tract. And that is a period that has come to be known as the hookworm flu stage. It's pro-inflammatory, which is probably deliberate, right? Because the adult worms want to bring the immune system to them so that they can dose them with their excretory products they don't have technically salivary glands, but they have the ability to secrete these powerful anticoagulants and immune modulating chemicals. And those immune modulating chemicals are the one that creates these populations of highly suppressive regulatory immune cells. And those highly suppressive immune cells will make copies of themselves, migrate out throughout the body, and make other copies of themselves. And that is how we can use a population of gastrointestinal worms to optimize immune function throughout the body.
And that's an important point for people who may find it disturbing to have worms in their body, kind of like the way you initially felt with the beef tapeworms, is that their life cycle, there's no reproduction of adult worms within the GI tract. They shed eggs into the stool, so there really isn't any risk of the initial inoculum expanding without being re-inoculated again, if I'm saying that correctly.
You are, right? And this is, I guess I should back up and say that for some people, worms are just scary, right? And worms are personally held beliefs, and there's nothing wrong with being afraid of worms. There are a lot of very bad worms, right? But we should add some nuance to that discussion, because not all worms are bad. And in fact, some of these worms seem to be lending themselves towards domestication, or that they've been selected through an evolutionary pathway that is more commensal or cooperative rather than pathogenic, right? Some worms have gone down a very pathogenic route. The guinea worm would be an example of those. But some of these worms seem to, a lot of our body is not us. It's a scaffolding that creates like a coral reef for other things to live in. And depending on who you believe, anywhere between 70 to 50% of our body is non-self. And the stuff that we can coexist with can make us healthier if we can peacefully coexist with it. So one of these features you're looking for in a worm that you can peacefully coexist with is something that doesn't expand its population out of control, so that you can manage that population, right? It's like, bringing a dog into your house. You don't want reproducing every year until you have 35, 50 dogs. You want to keep it in a number that you can manage. And that's one of the features of hookworm with that soil phase, right? They have to go through a soil phase before they can become infective. So as long as you're not out pooping in the garden, or you don't have a septic tank that overflows and you walk barefoot through the leach field, right, you're going to be able to control the population of this organism. And that can be a real feature of it.
Mm-hmm. So I just wanted to focus specifically on worm therapy for inflammatory bowel disease. And I know, this is something that has been studied, not specifically a lot with hookworm, but from the research that I've done on helminth therapy for IBD, most of the studies involve pig whipworm, but there are some with hookworm as well. And one of the encouraging things that I've seen is that there's really not any data from what has been published to show any serious adverse events. And I know you can control the inoculum as far as when you're using hookworm to avoid complications that can happen, like anemia, which tend to happen if you have like a very large inoculum. So that's one good thing. But there are 2 randomized controlled trials for pig whipworm, and pig whipworm is different in that you swallow the eggs, and you have to, and that's not something that stays in your system. You have to continuously swallow these eggs to have an effect, versus placebo. And they've looked at the efficacy and safety in ulcerative colitis, and they didn't show any significant difference from placebo with respect to inducing remission or clinical improvement. It wasn't statistically significant, but there was a trend towards maybe an effect. And then they've just done a phase 1 safety and tolerability study in Crohn's disease, also with the whipworm, and it didn't really assess for efficacy, but just safety and tolerability. And the only adverse effect was dysgeusia, but nothing else. So it seemed to be overall a safe treatment. So it's yet to be seen, and if it's effective with respect to randomized controlled trial data, but even that has issues. And I know you really can't comment on efficacy for IBD, and we really can only talk about certain people's experience and kind of anecdotal stories about it. And that's not our intention in this podcast to say it's effective for this condition or not, because really just the research isn't there yet. But what can you say about using helminth therapy for IBD so far in your experience?
Right. So when you look at the scopes of people with inflammatory bowel disease, to me, they look like desertification of an ecosystem, right? A healthy one looks pretty shiny and nice, like from the colon, a Gothic structure, and, it just looks healthy. But then when you get inflammatory bowel disease in there, you can see erosions, you can see fissures, you can see strictures. These all remind me of things that happen to riparian zones of rivers or the desertification of grasslands. And, so to me, again, going back, you have the gastrointestinal tract, and you have this thin layer of gastrointestinal epithelium, a single layer of cells that separates what lives in the gastrointestinal tract from the bloodstream, where we truly internalize things, right? Because the gastrointestinal tract really isn't inside of us, right? We're like this starfish with this river flowing through us that's really outside. So it's a very complicated ecosystem that has a lot of life in it that is only separated where it has to be cleaned up by the immune system. So, and part of that boundary is this healthy mucus layer. And when you take life out of that river, that mucus layer starts to degrade. And you can do that other ways too. You can have a fiber poor diet and then get a bloom of bacteria that eats your mucus. And then what you have is this bacterial lawn that's sitting right on the gastrointestinal epithelium. And then every time you eat, you get this translocation of bacteria into the bloodstream, and the immune system has to clean it up. And if you have a poorly regulated immune system, it starts making all these mistakes. So the idea is to put some of the life back in, get that healthy mucus layer, get the bacteria off the gastrointestinal epithelium, and then start getting blooms of the healthy stuff. And then hopefully the worms will make that population of regulatory immune cells so that you start to get better signal detection on what you should be tolerating and what is actually dangerous and should be being avoided. So it's a restoration project, trying to get all levels of that ecosystem healthy again, from the gastrointestinal tract to the mucus to the large multicellular creatures. And that there's different strategies on doing that. Sometimes people are so fragile that you have to use intermediate steps to get them to a better place, right? You change their diet, get as much fiber in there as you can, and then maybe you'll use a very gentle worm that only passes through. Pig whipworm could be an example of that, a non-resident species. And then if you get some stability in there, then maybe you can try to put the resident creatures in, which would be conservation from an ecology model. And that can be tricky to do because sometimes people are too far gone to put the resident species back in. It's just too fragile, right? It's like putting elephants desert. It's not good for the elephants. It's not good for the desert. But if you can get that to grassland and you get these large grazers in there, then they'll transform the grassland into forest and jungle very quickly. But it's tricky to do that. So clinically, my experience is that it's very individualized. Everybody's a little different. When ecosystems are healthy, they all kind of behave the same way. They're robust, they're resilient, they have good energy flows. But when they're broken, they break a million different ways. And it's hard to find an entry point where you can get some stability and then move them to a new fitness optima, right? Because usually these people are stuck in a pretty low fitness basin, and it can be challenging to move them to a better place because there's just so much fragility in there. And so we have a couple different strategies for doing that. You can do a fecal microbial transplant and get the bacterial lawn healthier. You can use non-resident worms and very controlled small populations, let the ecosystem rest. And this process is called disturb and observe. And in some individuals, you can just put the resident species right in and they'll take off. But it's a very individualized type of therapy. Everybody's different. And unfortunately, the properties of these complex self-organizing systems are such that they're dependent upon initial conditions. And if you have a lot of inflammation, it can make it hard to get a good outcome, right? Sometimes you have to use the drugs for a while to get people stable enough so that they can tolerate some of these organisms. And it's challenging, but it can also be a very good long-term solution in that if you keep the populations low and managed, you just have a healthy ecosystem that continues to improve over the years, right? And we would know this, like if you take a really ravaged soil, you can take it from basically desert playa, turn it into forest, but that process takes time, and the old growth will take time to do. So I think it's a really good idea to look at these type of therapies as long-term strategies. we get a little bit spoiled with the pharmaceuticals, right? I'm sick, come in, give me some pills, and then I'm better and I get back to my life. This would be more like exercise.
Right.
Eating right.
In the GI community, there is still controversy on, we know in inflammatory bowel disease, the microbiome is less biodiverse. That's been shown in multiple studies now. But there's controversy on if that's a consequence of the inflammation of some underlying immune dysregulation, or is that driving it and causing it? I personally believe it's the latter. I think that the less biodiverse microbiome is a consequence of multiple different things. As you said, maybe it's related to lack of breastfeeding, formula use, antibiotic use as a child and also into adulthood, living in very clean cities that we don't get the exposures that we would as if we lived in a third world country or in a rural setting. And these likely lay the groundwork for these dysregulated immune conditions to pop up. But there still is, it's not like definitively proven yet that depleted microbiome in IBD is what's causing the inflammation, or is it the inflammation causing the disrupted microbiome? So you mentioned that using medications, that's kind of the argument on the other side, is that medications are the cornerstone of addressing that immune dysregulation, and then as far as doing things to supplement the diversity of the microbiome, and those interventions haven't been proven yet. Now, you mentioned fecal transplant, which is a very hot topic right now in IBD. And one of the issues with a lot of the studies that have been published is they tend to occur in Western countries, like they're done in Europe and in the U.S. and Canada and Australia, and the donors tend to be from the same country as the patient, and which is a Western country. And I've always wondered, why don't they get donors from countries where they're known to have a more biodiverse microbiome? But that really hasn't been done yet. So a lot of the data for fecal microbiota transplant is not very strong right now. There is a signal that it may be effective, and it tends to be donor specific. Like there's certain donors that ulcerative colitis patients may respond to better than others. And that's further argument that the donor is important. So where you get the donor, why don't you get a donor from the jungles of like the Amazon, where we know that people are not in such a hygienic environment, and they have a more varied diet, more fiber, more exposure to helminths, parasites, these types of things that may have an effect.
Exactly, right. That was the thought process that I followed when we went out and sourced our donors, right, was that I wasn't interested in the Western biome. It's half dead.
Right.
When you compare it to fossilized poop or to modern hunter-gatherers, there's some great research being done in the East Horn of Africa right now at the Hasda, and that is, it's half dead. And you can't mix a bunch of half-dead stuff together and get a good product, which you see some of these trials doing, right? It's garbage in, garbage out. So, I know that it's controversial to some people that there's no cavemen anymore, but that's just not true, right? There's in a remote part of Mexico, there are a tribe of people that are still living in caves, and they have a little bit of agriculture, but not much. And we went and sourced some material from them, and their biodiversity tests off the chart. They also have a 40% child mortality rate and malaria, and a lot of those really negative interactions with nature that we've gotten rid of, but they have this extraordinary bounty of life that lives inside of them if they survive that gauntlet. And we've been using that material, and it is, to me, it's just a game changer, right? Because that is what you're supposed to be using. It's pretty clear from the scientific literature as it exists today that donors matter. And if you can get somebody who has had those experiences, organic food, no antibiotics, very active lifestyle, ordered interactions with nature, you get a very different product when you're using the fecal microbiota material. And one of the most interesting observations I've made in the last decade is that, because I've done this work on myself, I had a population of hookworms that I'd been raising incubations out for 10 years, and I thought I knew them pretty well. I knew what my dietary changes were to have a certain amount of ova production, and then you could use those ova to make an incubation of hookworms that we could use to treat people, and I would have certain yields out of that. And then I did a fecal microbial transplant from one of these individuals who grew up in a cave, and it tripled the overproduction of the hookworm living inside of me. Right, and this is really how ecologists study ecosystems. They look at the keystone species and they look at their fecundity rates, and you can use those as a measure of their happiness, right? Because all living things have an energy budget. When they're really stressed, they don't reproduce a lot. So what I thought was a happy, healthy population of hookworms in my gastrointestinal tract was quite stressed, right? And it's, in Western medicine, the presence of any large multicellular creatures is treated, right? We don't even tolerate that. We just kill them, and let alone studying how happy they are as a measure of how our ecosystem is doing, our whole body's biome. It's a very different place to be when you do these restorations. You have different metrics of health, right? So, and again,
so you actually had a fecal transplant yourself from, you mentioned one of these rural populations in Mexico?
Yeah, and it's unbelievable, right? One of the first things you notice is how much healthier that human being is than you are, right? There's this process of becoming a stranger in your body for a little bit, because yes, you are steering the organism, but there's something else running the engine. And so the first thing, you just feel just better, right? It's just a bloom of life is really the only way to describe it that's occurring inside of you. And I chose a donor that was, kind of my ideal. I'm a runner. I like running. So this tribe has some world-class runners in it. And, I was noticing that I was running better, that my fatigue walls were gone, that I was processing oxidative stress from the running better. And, I could measure all these improvements,
Okay.
I know there's also people that say these N01s is placebo, but man, if you can placebo the kind of improvement in athletic performance that I've seen, wow, that would be impressive, right? It's like a 14 or 15% improvement in my my run times.
Okay.
Plus, just more restorative sleep, different food signaling, right? I'd always had a really bad sweet tooth, and that transformed into more complex carbohydrate cravings, because it all makes sense, right? The stuff that's living inside of him has only been fed these very complex carbohydrates, and it wants to live. Those things want to live, so they modulate our food signaling system. The things that bloom inside of his body when he's running all this distance, are different than what blooms inside of somebody who's sedentary and sitting on the couch eating Cheetos, right? And those things want to live. Right, so it becomes your baseline eventually, but it is quite remarkable when you do that juxtaposition, when you're really just taking what's fueling the engine inside of someone else and put it inside of you. There can be a remarkable difference, and particularly because we had such different lives, right? I mean, he has something that's much more congruent to our time on this planet as a species than what I experienced. Right, it's really unusual for human beings to be born in a sterile hospital, not breastfed, fed antibiotics. What happens to us is familiar to us, but it is very strange. If you look at the time this planet has existed.
That you truly are a health adventurer. You're kind of blowing my mind here. Because I've always thought about doing that trial of at least doing like a case series specifically with this fecal transplant concept and not using a donor from a Western country. So I know you're saying it is an N of one observation, and you don't have inflammatory bowel disease, but you do have another disease of immune dysregulation, and I'm just wondering how did you practically get this done? How did you contact this tribe, and how did you, what was the way that the fecal transplant was done, and how did they agree to this, and what were the screening procedures? How did you get this done?
Yeah, well, so this is what I do. This is the field work, right? So it's not easy, right? You got to go to these really remote places, and there's huge cultural barriers, right? Almost every culture considers feces, kind of gross,
right?
And thank goodness humor, right? I mean, it's really lucky that what I have noticed is once people get past the initial shock, poop's funny to everybody. Poop jokes work, right? So you just try to make it funny, right? This tribe that I work with, they're very shy, and they have a concept of the good place and the bad place, that we would compare to heaven and hell, and they consider poop coming from the bad place. So, it's not easy to start that discussion, but, once they get used to you and they get comfortable with your presence, then you can start talking about, what you do for a living and how you can make medicine out of this stuff and help people. And the screening was challenging, right? Because everybody's a little different on what they're using for their serosurveillance and for their fecal testing. So we just did it all, right? We took the most comprehensive of the Western biome testing, plus we did a lot of the testing that you would do, or all of the testing that you would do for this part of Mexico, right? They have viral diseases, they have Chagas disease. So you just look for all that stuff. And I had been living in the canyon for a couple weeks, so I've been eating the food and drinking the water and didn't get sick. So figured the body has a method for ingesting this, right? Everybody in that canyon, they're getting the microbiome and they're sharing it, and they're sharing it through the food and water supply. So we did capsules. That was the way I did it. I thought top down would be safest. Put it through the stomach, let the immune system take a look at all the material. And then after the capsules were working really well for about a month or so, then went for the full-blown fecal microbial transplant, did an enema.
Okay. What kind of did you use capsules that release after they pass through the stomach, or what kind of capsules were they?
No, I tried that later.
Okay.
I tried that later, and it was just a disaster. I had every symptom of small intestinal bacterial overgrowth using enterically coated capsules. I think for our material, it's very important. It's too wild, right? And that environmental filtering, going through the stomach acid, is very important. Right? I think a lot of times the Western biome people get away with it because it's such a diminished product, and it's just not that wild. And so you can do enteric coated capsules and not. I just think the stomach's there for a reason, and probably a big part of why the stomach is there is probably to help clean up some of those fecal inputs that we get. So I like it that way. And it now allows. I've been doing it for 3.5 years, and the capsules allow me to control my inflammation on a day-to-day basis. Right? I just can't be doing enemas every 2 weeks.
Right.
It's just that's just not. It's just too disruptive. Right. And some people would be, and if I was sicker, maybe I'd be more motivated to do it, but I'm pretty healthy now. So all I really need to do is just keep my inflammation in the sweet spot so that, and I use that by my energy flows and how I'm running, right? Just if I'm running well and not getting those, a lot of runners deal with injuries, and, I just want to keep my inflammation so that I'm healing from wear and tear, but not so high that my body is overreacting to normal wear and tear and creating lingering injuries.
Okay. And at the point when you were just starting to do this, was your psoriasis under pretty good control, or did you notice like an improvement in the psoriasis too? No,
I was the worms had taken care of all the psoriasis, but there was some other stuff that I didn't really connect. And that was, I would wake up in the morning and I would have aches and pains in my knees and my ankles, and I thought that was normal. And what I learned was that that's not. That was some silent inflammation that was becoming not so silent, and that's not normal, right? You shouldn't have that. Okay. You can get rid of that.
Very interesting. Yeah, I brought this up. We recently had a GI conference where there was an expert speaking about fecal transplant for various conditions. And I brought up this point that we're not using donors from where we're supposed to be getting them. And, she said, she did say, oh, that's an interesting point. She didn't really have, I don't think they had thought of that concept yet. But then other people were saying, oh, Western populations probably wouldn't be able to tolerate such a diverse microbiome or potentially the parasites that come with it, or something like that. But I mean, I would assume you'd do the same screening procedures that you would do on a donor from the West, just do the same ones, maybe with some additional testing necessary if it's from someone from another, like Mexico or a non-Westernized country. But still, as long as you have those screening procedures in, it should be a safe thing to do. And it's a good thing if it's more biodiverse. I think the more the difference from the Western depleted biome, the better, as far as if you're looking for efficacy.
Yeah, I have been blown away with how well tolerated it is, right? Because, a lot of times you're not even supposed to go to Mexico and eat the food, drink the water, right?
Right.
And here we are taking raw material that is frozen. We want to create a physical barrier for some of the parasites. And strongyloides and the amoeba in the canyon, they don't do well with cold. So you give it a good hard freeze, ultra freeze, and then create that physical barrier. But you're taking raw material with minimal processing and putting it into somebody who's damaged, and the tolerance is unbelievable. It really is. It's pretty amazing.
Mm-hmm. So now I just wanted to go into a little bit more practical aspects of getting the worms. Now you operate the wormtherapy.com website, and you do offer worm therapy for people interested in trying this therapy. Now this is not an FDA approved therapy, which is why you are operating out of Mexico. Is that still the case?
That is correct, right? So the FDA does allow U.S. citizens access to experimental therapies if they have a serious medical condition for which there is no comparable therapy, and you start the therapy outside of the country. So this was a tunnel through the FDA approval process that was created during the height of the AIDS epidemic and still exists today, right? And then you're allowed to bring a personal supply of your therapy back to the States.
Mm-hmm. And where are you in Mexico now?
We're in Tijuana.
Okay.
Very close to the border, right? So a trip in, it's just 7 minutes across the border to the clinic and then back to America. Right? There's been studies done that people don't like to go more than 22 minutes into Mexico for treatment. So we try to stay well inside that buffer zone.
Okay. And I actually know Garin because I tried this therapy. I've mentioned that on previous podcasts that I've tried hookworm therapy. And I can just briefly go over a little bit of my experience. So this was back in 2011. I'm from Chicago. I just took a flight out to San Diego and met Garin over there. And we went and he drove me out to the clinic out in Tijuana. And another thing is, comprehensive testing was done. Like, you had sent me your lab results with regard to screening for any sorts of infectious diseases that theoretically could be transmitted. But my understanding is that there's never been known to be transmission of any kind of infectious disease with hookworm therapy. Is that still the case?
That's still the case, but right, better safe than sorry. Right. So just, yeah.
Right. So I got tested before the treatment, and then I saw Garin's tests, which were done by an accredited lab. So then I got the inoculum, and I remember it was 15 worms is what I was given. And it was a very simple procedure. It was just put on a Band-Aid. It was put on my arm. I just felt a little bit of itching that lasted for a couple of days. And there was a little bit of a rash that quickly went away. And then from there, I didn't really notice anything. Now, the whole life cycle of the worm, as far as going through the bloodstream, going into your lungs, coughing it up, swallowing it, and going into your intestine, I didn't notice any of that. And I don't know is that the experience of most of the people who come to you? Is that it's really just the itching and then from there, it's kind of on autopilot. I didn't really have any symptoms.
Right. Well, that's a pretty small population, right? We chose an entry point to the therapy that we were leaning more towards safety, right, than being aggressive. Mm-hmm. So you don't get as many of those side effects and or symptoms. And the larger the population, the more likely you get those symptoms, and sometimes it's subsequent. This is the first time that the immune system is seeing those worm proteins, and there's some priming that has to go on. So if you do a second or third inoculation, you'll sometimes start to pick up that cough or some of the other things. One of the trends we do see pretty clearly is that the skin reaction will become more dramatic each inoculation, and that's the worms aren't staying there. They don't really care if there's a big reaction there. It probably helps them. Little immune deviation, right? Like a lizard dropping its tail and then running off, right? But the gastrointestinal side effects usually become diminished because they're resident there, and those regulatory pathways are starting to get practiced, and the worms are getting better at modulating the immune system. Mm-hmm. I've done this long enough to see the exceptions to all of these, but it's that's the general rule of thumb and the trends that you see.
Okay. And one of the most interesting observations I had after getting the worm therapy, which I had for a few months, I think probably around 5 or 6 months, and then I ended the therapy. But I did have some mild asthma, which was not the reason I was getting the worms, getting it for Crohn's disease, but I had an exercise-induced mild asthma, and also it was induced by the cold. I would always get it when I would run, but that literally completely went away. And again, that's N equals 1. I'm not making any claims as far as efficacy, but my experience, and I can only speak about that, is that did completely go away. And it was a pretty quick result. As far as the Crohn's, I didn't, I actually felt perfect before getting the worms. I was on that diet, the specific carbohydrate diet. And my whole rationale for doing the worm therapy was to help me. I wanted to do something to kind of replace the diet because I'd been on the diet for some time and was hoping to expand it and see if this could allow me to tolerate more foods. Ultimately, that didn't happen. I kind of, after the worm therapy, got a little bit worse over time, and I hadn't really expanded my diet that much, and it was still within what the diet allowed and still was getting a little bit worse. So I decided to end the worm therapy by taking medicine, and I ended up getting endoscopies to make sure I didn't have it anymore. But again, that's just my experience. But I wanted you to go into, as some of the people that you've treated with ulcerative colitis and Crohn's disease, and we're not saying this is an approved treatment or anything like that, but just anecdotally, your experience treating patients with ulcerative colitis and Crohn's disease, what has been your observation? And I believe, this is probably true, that you are probably getting people who are failing many different treatments, probably people who are not responding to medication. So you're getting probably pretty severe people coming to you, and it's not surprising that some people may that patient population may not respond compared to somebody who had maybe mild disease, potentially may get a better response. But at this point, we don't know. Right. We don't have the data.
Yeah, and I think that sometimes Crohn's is more an umbrella diagnosis than it is specific.
Right.
I think that we probably got 4 or 5 different kinds of Crohn's in there, and each one of them is going to require probably a different strategy. But we just don't have any way of categorizing that right now, right? It's just, it all kind of gets lumped together. And, the Crohn's it's a very difficult adversary, right? There's something that's going wrong in Crohn's that it's just a tough one. You add to that, it tends to be less responsive than ulcerative colitis, that it scars, right? Compared to ulcerative colitis as a non-scarring condition, it's just stubborn, right? Whatever inflammatory switches are getting turned on are probably very close to the master switches, and they're hard to turn off. Mm-hmm. So what we try to do now, when you and I were working together, it's been long enough that we have moved forward, right? And some of the strategies that we would use. We may use a gentler non-resident worm to try to get some infrastructure built in there, right? Get some remodeling of the bacterial lawn towards a more natural place. And then we probably start doing some fecal microbial restoration, try to get some of those other pieces that help educate those regulatory immune cells, right? Because they're educated. They interact with the bacteria in the gastrointestinal tract before they're released and sent out to go turn off inflammation, right? Because they have to be taught what to tolerate. And if you don't have a lot of that life, you're only getting partially suppressive regulatory immune cells. And it's also tricky because life gets in the way. I remember the time we were working together, you're real busy, right? And you don't always have a lot of time for these kind of experiments. You just have to feel well. And creating a window where people can do this work, which sometimes requires patience and diligence, can be a challenge, right? Modern life doesn't always cooperate when we have so many demands on our time.
Right. And do you feel like, and just anecdotally speaking, are there people who have gotten durable responses to this? And have you heard of anybody getting a scope afterwards showing healing? And again, this is just anecdotal, not regard to broad efficacy, but have you had people who've come in who have had success with this for like long periods of time?
Yeah, right. The small bowel presentations of Crohn's in particular, for some reason, very responsive. They're overrepresented in our super responder category, right? Some people, they're just missing a couple little pieces. You put the worms in and they're just off to the races.
Okay.
Others, no matter what you do, we can't get it calmed down.
Okay.
Once you get a lot of inflammation and you failed at all the medicines, we're in trouble, right? Because those regulatory immune cells that the worms manufacture are context dependent, which means that they can be pulled into the inflammatory cascade. Even if they are intended to be regulatory immune cells, they can still wind up feeding the fire if you can't get the inflammation turned down. And, sometimes you have these inflammatory bowel cases that come in and they're already at 60 milligrams of prednisone. They're still flaring. They failed at the biologics. And, it's just really, really, it's a lot to ask from a small population of worms to put out that fire.
Right.
It's preferable to get it in there when it's healthier.
And have you had any issues with people on immune suppressive medications? Like, is that a potential contraindication to getting worm therapy if someone's on something like Remicade or steroids?
No, but methotrexate.
Okay.
That's in one of the treatments, and that's just such a poisonous drug, and not that methotrexate doesn't have its role, but it's just a very hard drug on life in the gastrointestinal tract, right? So there are some drugs. There's one drug for Crohn's that messes with white blood cell production. Well, we want to make white blood cells. We want to make a very, very specific type of white blood cell. But if you have that pharmaceutical on the way, you need to get that out of the way so that you can have the worms doing what you want them to do. Mm-hmm. So there are some contraindications, but we usually can substitute or wean. There's strategies, that you can use a non-resident worm for a while and then wean off that drug, and then you can go to the more residents. It's a little different for everybody, right?
And you said you've observed that some super responders have been some people with small bowel Crohn's disease. What about, are you getting people with ulcerative colitis seeing you too?
Yeah. Ulcerative colitis is, it's one of about a third of what we treat is asthma and allergies, a third is inflammatory bowel disease, and then a third is everything else. And so the ulcerative colitis is about half of what we see in the inflammatory bowel diseases. Okay. And you start to have your favorite cases and what you don't like, right? Just based on how you're doing with the populations of those clients that you're treating. When you're seeing a very advanced case of Crohn's, that you've got a very long road ahead of you, right? Mm-hmm. Some of these ulcerative colitis cases, I mean, also a lot of people suffering from inflammatory bowel diseases just have incredible urgency and frequency issues in going to the bathroom, right? These poor people, they're the best people to travel with because they know where every single bathroom in the city is, right? Because that's their life, right? Bathroom to bathroom to bathroom. And, so one of the organisms we work with, this non-resident worm, causes constipation, right? So you can be transforming their life very quickly if they're responding to it, right? They'll go from 12, 14, 15 bowel movements, 20 plus bowel movements a day down to 3 or 4, right? The quality of life between those two is enormous.
Mm-hmm. And once people get inoculated, as far as long term, what is expected? Do they, how long does the hookworm usually last, and how do they keep up with this treatment if they do respond?
Right. So if we're using non-resident worms, that's something you have to do, every 3 or 4 weeks for the rest of your life, right? Because they're not living in there. And some people like that, other people don't. If you're doing something like hookworms, what we're seeing are hookworms living somewhere between 6 to 14 months in the Western biome. And when we do the fecal microbial restoration, we're seeing that go out to 2 to 3 years, right? So, it just really depends on where your bacterial lawn is and your permissiveness as a host. Some people, particularly people who are really allergic, are non-permissive hosts. If they lived in a village, they'd probably really be good at keeping their worm burdens down. But when you're trying to host a population of worms in the modern world for the long term, that's a disadvantage, right? Because you're going to be kicking your worms out closer to 6 months than somebody who's a more permissive host and is going somewhere around that 14, 15 months between inoculations. It's because it's a living population. You want to keep it fresh. Put some youngsters in there, keep everybody on their toes. It's just a way of managing a population.
Mm-hmm. And I remember when I was considering this therapy, I called a reference you had provided, and he was telling me, I think he was using it for more allergies, seasonal allergies, and he was actually re-inoculating himself by harvesting the eggs from his own stool, and doing that on a somewhat every 6 months to yearly basis. So is that still an option for people to do, or would they more get the worms again from you?
Yeah, that's an option, right? I mean, essentially, when you come down and you're treated, you have a lifetime supply of worms, but you do have to master the ability to incubate them and then clean them up and then inoculate yourself. A lot of people don't like doing that, right? Because they can, I can change the oil in my car, but I pay somebody to do it, right? It's just a better use of time. So it's really up to the individual. Kind of science-minded, you like working with a microscope, it's something you can do. I see the pros and cons to both of it, both ways. But that's why we do those 2-year contracts, right? We do want you to work with us for a couple years before you go off on your own. Because one of the common mistakes that we see a lot of people, and I made myself, it's just one of the more common mistakes, is that if a little is good, more must be better. And that's just not how ecosystems work. There's a sweet spot, a balancing point in there that you want to get. And then that way you can develop this strategy for a sustainable population, because these worms are not little angels that fell from heaven to help us, right? They are a living creature that have their own agenda. And if you're not careful with them or you make bad decisions, you can build that population up to a level that they are no longer cooperating. They're just a true pathogen, right? And so for Nicator americanus, when you get about 110 of these, you're going from a mild infection, which is something that you could live with for decades, to a moderate infection. And now you will be straining the iron pool. You'll have vitamin A issues. You'll probably be messing with your sex hormones. These are, a lot of those are just consequences of iron metabolism, but you can get significant enough blood loss, and that anemia that develops is insidious. It's very hard to recognize at first, and then it can get quite out of control, right? And then I have seen some do-it-yourselfers that take themselves up into a severe infection. And when you do that, I mean, you got to be careful, right?
Mm-hmm.
It's nature.
Right.
And she doesn't tolerate, mindlessness or carelessness. You got to be thoughtful about these populations. The thing that we all did is that we're coming from a place of being very sick, and so then you start to feel better, and you want to explore that upper boundary. But I think it's helpful to have somebody helping you make those decisions, right? So that you stay in a safe area. And a lot of times it's not the lack of worms that's the problem, right? People wind up exploring that upper boundary of what their ecosystem can carry because they're trying to fix another problem that the worms can't fix. And I think a lot of times that's in the bacterial lawn, right? Mm-hmm. That you're missing half the life there, and you're asking a small population of worms to, it can't create out of whole cloth these bacterial communities that we've had that are now gone, right? It's like there's a researcher at Davis who says you can build a zoo, but you're not going to have hippopotamuses spontaneously arise. You got to put them in there, right? So I think it's just a little bit of frustration that we don't always have all the tools we need in the toolbox to do these restorations.
So just to be clear, I wasn't aware of this. Does your company just offer the worm therapy, or does it also offer this fecal transplant along with it from these like rural populations in Mexico?
Yeah, that's what we do, both of them. And the reason we even started to do the fecal microbial transplants was because I got so tired of our long-term worst worm responders losing their benefits when they would take a course of antibiotics. And just what we would see over the years would be somebody like with lupus who was doing great, and lupus completely in control, and then they got a urinary tract infection, and they had to take a round of antibiotics, and then the worms would go offline, and the lupus would come back with a vengeance. And a lot of times lupus is scarring, and we had very little kidney function, so there was no room to be just waiting while that scar tissue accumulated in the kidneys. And we needed a way for the bacterial lawn to recover faster. Mm-hmm. And whatever was going on in the Western world wasn't fixing it, right? Some cases were taking up to a year after the antibiotics for the worms. No matter how many worms we put in, we couldn't get the therapy back online. So that's what sent me out into the field to try to find a more complete microbiome so we could get the worms working again. And, you're like all experimental therapies, you start with your most pressing cases, and then as you learn what you're dealing with, then you start to expand who you treat with it. And so it's been 3.5 years now, and we're seeing that a lot of these restorations have to be done together, right? Mm-hmm. There are some responders that only need a small population of worms, but most of us need a lot more work than just that.
And have you used this combined approach with the fecal transplant as well as the hookworm in any inflammatory bowel disease patients?
Yes. Mm-hmm.
Okay.
Yeah.
And overall,
they're among our most challenging.
Okay. And have you noticed a difference between what you were doing before, which was just worm therapy, versus the combined approach? Has there been a boost in the effect, at least on an anecdotal basis, from what your experience has been?
Without question.
Okay.
Right. I mean, the worms are amazing. I would never take anything from them, but the fecal microbial restoration is just a whole creature unto itself. I mean, the worms are one species, maybe two species, if you're hosting a couple of them. But the fecal microbial stuff, right, is tens of thousands of species doing things. And it's just a real rebiosis. Mm-hmm. I don't want to get hyperbolic in all this, and I don't want to oversell to anybody, but we have a public health policy that cleans things up, and all those individual decisions were very good, right? We cut the child mortality rate to an absolute fraction of what it was. We got rid of malaria, cleaned up our food supply. These were all good individual steps, but the aggregate of all of those steps has removed so much life from us that I would say that most of us don't even really know what healthy feels like. And I'm not saying that I'm that healthy. I just know that where I came from, I thought I was doing okay. And I realize now that I was just a shadow of who I could be. And so if the only metric we are looking at in public health policy is how long people are living, and we're not looking at the quality of their life, we're making a terrible mistake, because we're having children born today that are never going to know a single day of wellness or health. They're born with a chronic health condition and they're going to die with a chronic, and everything in between is going to be treating the symptoms of it. And I think many of us, and myself included, if given a choice between living to 76 or living to 72, right? But I felt the way I feel now versus the way I felt for the first 35 years of my life, there's no question. I will give up some of those years on the end of my life to have this completely different experience with the world, right? And absolutely, you see it all the time, doctor, right? The downward drift of autoimmunity. Your life gets so small. And just think about the inflammatory bowel people. They can't even go to the grocery store without having to make 3 stops to go to the bathroom, right? When you get that fixed, if you don't have that, well, now you can travel around the world, right? You can kayak down the Colorado River, right? I mean, there's just, your world's big in a way, and we have to stop focusing and throwing our arms up in victory. Oh, everybody's going to live to 82. Well, go walk around Walmart and see the quality of life. Look around. Look at the quality of life these people have for those 82 years. Right. I don't see victory there. It's not mastery of nature, right? I don't. Yeah. I've had some experiences that isolate me now when it comes to where I think our public health policy should go. And I know some of these ideas are strange to people, but.
No, I totally agree. I think, quality of life is definitely the most important thing. And specifically when we're talking about inflammatory bowel disease, what you're doing is very, very unique in that you're targeting something that's not targeted in the standard of care model that we use to treat IBD, because we're using medications mainly to target the immune system. And that is somewhat of a Band-Aid, because it's blocking certain, cytokines and the inflammatory process, but it's not getting to the underlying cause. Now, some people may disagree with me and say, at this point, we don't know what the cause of inflammatory bowel disease is, but my sense that it is microbiome driven. That's my opinion, but other people would say that, we don't know. But what you're doing is you're targeting the ecology, the gut ecology, and it's yet to be seen how effective this can be. You would even admit your experience is anecdotal when the clients that you use, but it seems like you've seen some people do well with this. And I think the future, they are doing fecal transplant studies as we speak, but not in the way that you're doing it and then getting donors from Mexico and probably have a more biodiverse microbiome. So it's very interesting what you're doing, and I really hope that this is studied so in like a randomized control trial type of fashion to see if this is really effective. But as you said, there's problems with randomized control trials. You just mentioned that Crohn's disease is probably multiple different diseases lumped into one, which I agree with. There's probably multiple different causes and leading to a common phenotypic expression that is similar amongst these different conditions. But you lump them all together as Crohn's disease and you try one treatment in that group when they may have different diseases that may respond differently, and you can have a negative result compared to placebo when there may be a subgroup that does respond, that may benefit, but we're not giving it to people. So another interesting thought I had regarding Hellman therapy was the potential to prevent autoimmune disease, because autoimmune diseases are difficult to treat in general. They're chronic conditions, and a lot of times the medications have undesirable side effects, and it's just hard to control. I would think it'd be much easier to prevent these from coming about than treating them once they start. So so I always thought, like, oh, why not have hookworm or some other helminth as almost like a vaccine, in quotes, to help prevent the development of inflammatory bowel disease. I looked into this, and there's only one study I'm aware of where they looked at there's like a South African population, and it was a case control study of patients diagnosed with inflammatory bowel disease, and they compared them to patients with other conditions, and they asked them about if they had a childhood helminth infection. And 66% of the patients with inflammatory bowel disease did say they had a childhood helminth infection versus 91% who had other conditions that were not autoimmune in nature. And so it seems like if you get a helminth infection, it doesn't completely prevent it, but it definitely seems to have some effect. But it's not like completely going to eliminate your risk of developing it. But that's maybe too simplistic of a way of thinking of it, because as you mentioned, it's not just hookworm, it's diet, it's your microbiome, your environment, like how often you're outdoors. These different things contribute. Your circadian rhythm.
Right. And I think a lot of what this work is that I do is just helping people become experts in managing their gastrointestinal ecosystem, right? And all of the inputs that are required to keep that healthy. And when you turn the noise off, right? Because when you get sick, you get all this inflammation. It's random. It's chaotic. There's all this noise in there. You can't figure out what's making it worse or what's making it better. But when you start to get that inflammation turned out, you start to understand the foods that are your triggers and how to nourish your body, proper sleep hygiene, start incorporating the movement into your lifestyle, creating a social support network that has a spiritual component, that has, robust interactions with other people who are taking care of themselves, right? That's all part of this, and it's very hard to reduce that kind of stuff down to a double-blind placebo control, right? There is no pill for social isolation, right? There is no pill for exercise. It's just complicated. It's really, really complex. And, so that one of the things that frustrates me is that when the fecal microbial transplant people in the Western world are looking for donors, they're letting them self-report if they're healthy. As I've mentioned, I don't know too many people in the Western world that really know what healthy feels like. And there is no test for a microbiome that predisposes you to psoriasis. There is no test for the microbiome that predisposes you to multiple sclerosis, right? Some of these conditions take 20 years to develop from initial symptoms to diagnosis, right? So you got to be real careful about allowing. So where do you in the face of sustained scientific uncertainty, turn to nature, right? See what she's doing. And to me, go find donors that don't have any of these conditions, right? And it seems like if you go past a place where there's no development, and a point of lack of development, they are completely inoculated against these diseases. They don't have names for them. There's parts of Africa that don't even have a word for wheeze or asthma, right? Here in America, asthma kills 6,000 people a year. That's almost 2 9/11s a year.
Yeah.
Besides, it's the number one cause of emergency room visit, right? What are they doing different from us, right? That they seem to be completely inoculated against these diseases. But if they come to America and they live for a generation or two, they pick up all the same diseases, right? So that tells me, right, that there's some things that we're doing wrong. And I come to believe that there is a sweet spot for all of us between that village existence and the city existence, right? I've seen in the village, they have incredible biodiversity in their biome, but they have almost no financial opportunities. In the city, we have extraordinary financial opportunities, but we have very little biodiversity in our biome, right? So in between these 2 points for all of us are is a sweet spot, a fitness optima, or maybe a couple, and you just rewild and rebiose and nudge it towards one of these new fitness optima. And then you find a way to marry the best of both worlds for all of us, right? Because you and I are the end product of a family that left the village to explore financial opportunity. Mm-hmm. And I feel very blessed to have been born into a country at a time of the world where we have so much, but I also recognize that I was not healthy having so much, right? And now I hope that I'm getting myself to this place where I get the best of both worlds.
Mm-hmm. Yeah, I'm similarly frustrated. You know, we have this information, and what you're saying makes complete sense, but as you mentioned, the interventions likely required to help prevent these conditions or potentially treat them, they're multifaceted. You know, it's not going to be just one thing. And then the way conventional medicine goes nowadays is you need very strong evidence to recommend something. Like, it pretty much has to be in a very high impact journal to change the way people think and the way that people practice medicine. So unless you're when you're talking about GI, unless you have some intervention that's proven in the setting of a randomized controlled trial, and even then, it probably has to be published in either the American Journal of Gastroenterology or the New England Journal of Medicine for people to really take notice and for it to change things. And that's a double-edged sword. It's good in that it's a very high standard of evidence, but some interventions don't lend themselves to being studied in that way. Like, what is going to be stuff that's, in order to study things, a lot of what's studied is what's easy to study. And that's medications, because it's easy to study medications because you can have a matching placebo that's exactly the same, at least by appearance, to the interventional, the drug that's being used. But how do you study diet? That's a tough one to get a proper placebo control for. And it's also, a diet is so varied. It's not one thing that you're giving somebody every day that's in the form of a pill. And how do you measure compliance with diet? And then if you're adding on to diet, you know, maybe a fecal transplant or fecal transplants you can probably blind for and do placebo control. But when you combine multiple modalities, it's difficult to find a placebo to match that because you're doing multiple things. And as a result, those things don't get studied. Why? Because they're too expensive. It's too expensive to do such a study. It's hard to find patients that are going to cooperate with all of these interventions. And also measuring outcomes can be difficult too. So that's why this stuff doesn't happen. And that's why the current standard of care is dominated by medication. It's just because they're the easiest things to study. And that's what's been published. And we have data, convincing data, that medications work. But are there things that work better? Probably. But, I mean, it's just, we're stuck. We're stuck in this area where there's all this information that makes sense, but we can't prove it because we don't have the apparatus to do so.
Yeah. So this is optimal foraging theory, right? When you're trying to discover the unknown, and how do you do that? And that's, you know, it's all trade-offs, right? So we have a system that keeps us from making a certain type of mistake, but it maximizes the chance that we miss something easier, right? And if you go the other way and you maximize the chance of not making a mistake, you miss. It's all of the universe is trade-offs, right? And the medicine exists in one system, and if you get sick and you're not working in that system, you're going to have to do some foraging, right? And that means tolerating some of this messiness that you get when you come out to the frontier. And not all this stuff has been studied. It may never be, right? A product like fecal microbial transplant is so complex, we may never really figure out what we're doing, right? But, you know, sometimes your outcomes can get ahead of the science. It doesn't mean the outcomes are bad. You know, it's just... It's very hard. I have great sympathy for the regulators, right? Because they're given this really difficult job, and doctors are the gatekeepers, you know, for the lay public to access to these therapies, and it's hard. You get burned by therapies that you think are going to be great, and then you find out that they were like Propulsive, the drug that I was on, was supposed to be this miracle drug and help people with non-ulcerative dyspepsia, but it gave them heart attacks, and it took 7 years to figure that out, and that's doctors get burned by that so many times they become reluctant to. Right. And then you get an like worms and fecal microbial transplant, and everybody gets real cautious. But one of the things that my critics say is that we will just take the worms and we'll make a drug out of them. And what I want to attack that for your audience so that they understand what is actually being told to them, right? Now, because of the approval process and how hard it has gotten and all the low-hanging fruit is gone, you're probably looking at 20 years from a molecule being isolated to a doctor being able to prescribe it for you. And then you have another 20 years from it being prescribed to collecting the safety data in post-marketing. And that's when you'll really know what a drug does. So you're talking about 40 years. If you can wait 40 years, then wait for them to make a pill out of the worms, right? Mm-hmm. But if you can't wait that long, then you have to start this foraging behavior. And that is, the internet is amazing at that, but there's a lot of bad stuff out there too. So, right, so you got to figure out how to filter all of this. For me, I just think we've gotten it backwards, right? We're not afraid of the drugs, but we're terrified of nature. And I think that's and if we had a healthier respect and interaction with nature, I think we would find that's the opposite. I'm not saying I take drugs. I got mugged once, had my jaw broken, and I took my antibiotics, right? Mm-hmm. I'm not saying it's drug, but I'm just saying that, when we say that we'll make a molecule out of worms, think about that for a second.
Right.
Can we really reduce a life down to a chemical? Right? If we could do that, why do we need conservation? Right? Why do we have to save polar bears and whales and penguins and birds? We could just make a chemical, but we can't. There is no Monsanto scientist right now making us a hummingbird pill, because that's just absurd. Mm-hmm. Right? Hummingbirds do kinds of things in an ecosystem, and we're already half dead in our gastrointestinal tract, and each one of these pills is not going to improve the overall health of the life in that ecosystem, right? And we're already taking 5-7 pills a day once we get to 50 in America. So how many pills can we take a day, before the pills kill us, right? So
then they're saying the same thing about fecal transplants. They're trying to reduce that to a few strains, like They're looking for the exact strain that's going to take care of inflammatory bowel disease. Maybe that's possible. I have a gut feeling that that's not going to work out. I think, as you said, you need it's hard to reduce these things to a single element, because it's too reductionist. They assume that they can create the isolated molecule or protein or bacteria, and that's just going to take care of things. But there's more to it than that, and I think that's probably doomed to failure. But we'll see. I may be wrong about that.
Cracks that nut, they're going to help a lot of people, and they're going to make a fortune. But if you study complexity theory, the way these populations work together and the things that happen with action over a distant and emergent property, you can't just walk into something that complicated and start saying good and bad. It just doesn't work that way in nature, right? Yeah. The naturalists speak about this at length. You tug on one thread of nature and you find it all interconnected. Mm-hmm. That's what I think we've done. We've been doing this command and control model of gastrointestinal ecology management for the last 100 years. We've expanded lifespan, but we have shrunk health span. And until we start paying attention to that health span metric and get those two numbers of equal weight, I just don't think that we can do the math properly. We're just making a mistake.
Yeah.
And I hope that we're doing down in Mexico, and that you're doing, that we're going to get this, maybe pointed in a different direction for a while.
Right. And I do agree that these indoor lifestyle something about the indoor lifestyle is likely contributing to these diseases of Western civilization. I've always had an idea of taking patients with any kind of immune dysregulation disorder like inflammatory bowel disease or psoriasis, and as the intervention, if you were going to do a clinical trial, is just have them live outside like 24 hours a day. And with the control group would live inside as like normally you would in any Western city, and just have them live outside and see what happens over the course of a couple months and see if it really changes outcomes. Because I do believe getting out in nature has effects that we don't even recognize yet. I mean, people talk about circadian rhythm, talk about light, talk about just even your microbiome is influenced by being outside. So that's another thing I was thinking. These are all just ideas that I have about research projects in the future, but it's hard to research these things.
Make sure you feed them the same thing, right? So you don't wipe out your signal. But yeah, I absolutely. I mean, this is what we do with the worms, right? And the ancestral fecal microbiome material. We're just helping people reorder their interactions with nature, right? It's the forest bathing that the doctors in Japan prescribe, right?
Exactly.
You just go out and you get some nature. We see ourselves as conquerors of nature when we really should see ourselves as citizens or participants, right? And these Indians that I work with, they have a concept of irigawa, which is a broken soul, right? And one of the ways you break your soul is to be disrespectful of nature or disconnected from nature. And when they come here to America, they see it, right? We're very disconnected from nature. And we did that for very good reasons. I'm not saying reject running water, indoor plumbing, electricity, but you got to find a balance, right? If your kids don't know what a carrot is, right, you've got a problem. And you got to get them reconnected to nature in a way.
Right. And you mentioned that there is stuff out there that is quackery, that the way that I kind of filter through that stuff, and believe me, before, I was diagnosed when I was in medical school, and I kind of went down this internet rabbit hole, as I call it, trying to figure out different treatments to try. But I'd always filter it through what makes sense evolutionarily and what makes sense epidemiologically. And I only have tried things that made sense. Like I try to put myself back in a time where inflammatory bowel disease likely didn't exist, and what were the circumstances around that, and try to reproduce that. And everything I do is and the ancient people from the caveman wasn't the picture of good health in some certain aspects, like as far as infectious diseases and things like that. We have better treatments for those now. But when it came to autoimmune disease, it's unlikely that it was as much of an epidemic as it is now. So why not try to reproduce some of those circumstances that they lived in without the other dangerous aspects, like we don't have to hunt anymore or run from lions or things like that may have been a problem back then, but we can still reproduce being outside, eating that type of diet, sleeping, like staying in a good circadian rhythm. So those things you can reproduce with still maintaining the benefits of a Western lifestyle, and maybe can address some of these health problems.
Exactly, right? It's not all or none. We don't have to all go back and live in caves, right? But you can find a sweet spot, right? Maybe we don't need to be running from lions all day, but maybe we structure 30 minutes of the day that we do go run. Right? I mean, you can do little bits of it. Maybe we don't have to know the true pain of hunger from a drought, but maybe you do a little bit of intermittent fasting a day or two a week, right? To get the benefits of it. Right. And that's the balance, right? Come back into balance with nature instead of beating it into submission with pharmaceuticals and surgeries and stuff. And not that those aren't lifesavers. They absolutely are. But there is, I think, a strategy for long-term coexistence with nature that is better, right, than having to bounce from crisis to crisis.
Right. Well, Garin, I don't want to take any more of your time. We've already got about an hour or 40 in, but I really appreciate your time. I think we're in agreement with a lot of these concepts. Unfortunately, every time I do this podcast, I feel like I'm walking on eggshells, and I'm sure you probably have a similar feeling because these treatments are exciting. They're interesting ideas, but we can't make definitive statements that, you should try this. This is something, any of these treatments that are discussed, you need to discuss with your gastroenterologist or physician before trying them. And this isn't something necessarily I am recommending for anybody who's listening today, but I'm an open-minded person, and I like speaking with people with different ideas. So, and Garin, if people do want to contact you and are interested in getting more information, how do they do that?
No promotion by providers of experimental therapies to a U.S. Audience, right? Mm-hmm. So you can find me, right? You're going to have to do some research. You have to go out into the internet and do some foraging, but you can find me. Okay. But yeah, I don't, no promotion.
Right.
So, and the FDA has different definitions of promotion that's hard to keep track of. So it's just better to, I like to plant the seed of this idea, and then you're going to, people who are interested in pursuing it, they'll find communities that have sprung up, Facebook groups, Yahoo groups, right? And you get involved in those communities, and they can get you pointed towards the providers that have a good reputation, right? And that's, it's all very, very doable. You don't have to go to Africa and infect yourself with a tapeworm by yourself like I did, right? We've moved past that.
Right. Okay, great. Anything else you wanted to mention? Otherwise, again, thanks for coming on. And maybe we can do this again sometime if you come up with any updates to your protocol. But so far, very interesting work you're doing.
Well, thank you. Yes, I enjoyed the conversation immensely. You can tell we're both very passionate about this. So
yeah,
fun to talk about.
Thank you.
Oh, my pleasure, Doctor.
So, and then Reed, did you have anything else you wanted to mention, or any questions, or?
No. I mean, I know that you've been doing treatments, so my question would be to hear your story, but I think you said you're going to do a podcast about that. So I definitely encourage you to do that, and I look forward to hearing about your experiences with all of this.
Yeah, I do plan at some point to do kind of it's probably going to be a multi-part thing, because I think I do have a unique perspective that I do want to share, because I think I started out with this diagnosis of Crohn's disease, and it's really come along with many twists and turns. That initially, I was diagnosed in medical school, and I, like you, my journey started with a specific carbohydrate diet, and it's been many, many years of trying different things, and ultimately finding success, and then ultimately specializing in this and training with some of the top, inflammatory bowel disease physicians in the world. And so I've kind of been on both sides of the curtain. I've been on the side of going down that internet rabbit hole and trying all these things and being confused and getting really devastated by side effects of medications, and demonizing medications and being absolutely afraid of them and against them, and then kind of going through the training and seeing the other perspective of why we use these medications. And now I'm kind of developed this framework in my mind of how to address these conditions. So yeah, I plan to do a podcast. When that is, I'm not sure. Part of it is just being comfortable telling my story too, which, it takes time. And but eventually I will go through all the details, because I think it is a good thing to learn from what I went through.
Yeah, absolutely. I completely agree. That is a very unique perspective, and one that's much needed, just so that you can connect with your patients and so that they can feel like they have a partner in this. So kudos to you for going on that path of, being on both sides of the spectrum.
Oh, thanks. Yeah, I just think it actually helped me out, because in medical school, I didn't really have any particular interest. I went into medical school not knowing what I wanted to do. But then this happened, and I was like, all right, I might as well do this, because it just helped me to get up every day in the morning. It's like, okay, this is actually something I'm interested in learning about.
I got to figure out how to cure my own shit.
Right, exactly. And then actually, believe it or not, I was going to be a dermatologist before this all happened. Mainly because I had a good lifestyle, and it was I thought I'd be happy, but I knew that I had to pick something that I'd be passionate about and that I'd cared about, and that would ultimately, because it's all about being happy, right? Even when you're trying to figure out these treatments, figure out what works for you, you got to pick something that's going to lead to a better quality of life, and as you said, allow you to reconnect, right? Connect with people and be happy and be passionate and do what you want to do.
Yeah, absolutely. I've found that, if you try a treatment that you don't think is going to work, you're right. It's not going to work. It's half of this battle is the mental game. Yeah,
exactly. All right. Well, thanks again for coming on. And to all those listening, please subscribe. Try to share this on any social media platforms that you can, so that more people can listen. And hopefully we'll have more guests soon. All right.
Yeah, thank you so much. Really appreciate talking with you.
Thanks.